Hello and welcome to Therapy Chat with Phoenix Behavioral Health. I am Dr. Dawn Parks, and with me is Christine Delorier, and today we're going to talk about schizophrenia. So schizophrenia is something that is very scary to a lot of people, and when we look at the media, it's often depicted in a very scary way, a very negative way. So schizophrenia changes the way that we think, the way that we feel, the way that we act. And it affects people a little differently, individually. Symptoms can come and go. And we don't always have all of the symptoms all of the time, so it can change. But typically schizophrenia is diagnosed fairly young. It's age 16 to 30. Seems to be a little bit more common in men.
And I think it affects men a little bit earlier too, more late teens, early 20s, and women more later 20s, maybe up to 30.
Yeah. And so we have this term, it's called prodromal. So the prodromal phase is when a person may be experiencing some changes, but they're very subtle, and they're leading up to more of something that's much more obvious. So it's very devastating because a person could be highly intelligent, highly functional, and then there's just this what seems to just suddenly happen relatively quickly, where a person may have hallucinations, have different experiences, and the symptoms can go from very mild to extremely severe.
I think also as with most everything that we've talked about in general, stress is a factor in terms of bringing it on. I think there's some genetic component, there's an environmental component, there's a brain chemistry component to it, but also I think stress, like you see a lot of these mental illnesses come on in college years because you're having irregular sleep, there's pressures, there's stresses academically and socially that you didn't maybe have in high school, and then a whole nother aspect to this is substance abuse, and a huge trigger and to a lot of problems with schizophrenia is substance abuse induced schizophrenia, which we see happen quite often. So I think all of that is a triggering for that age category of things that can come on sort of out of all of a sudden that you weren't seeing a few months ago or a couple years ago.
And we have to keep in mind that it is a treatable mental illness, and often we'll see a person who is currently having a lot of these symptoms going on, and it may lead up to hospitalization, but usually after a relatively, it depends, but a relatively short period of time, person will come out, be stabilized, and it might be a while before they go back in for another period of hospitalization. It might not happen. One of the biggest things that happen is a person gets stabilized with meds, and then they're doing really well, and then they stop taking the meds, and then that leads to another crisis.
Right. Or in the case of substance abuse induced schizophrenia, they will, which often the drug that triggers that is marijuana. That's pretty much almost 100% the cause of it. And what they will do is they'll get off the psychotropic meds, they'll be doing quite well, and they'll go back to using pot, and it triggers a whole nother episode all over again, back in the hospital, back on meds. And the more times that you have relapses and episodes, the less likely I have seen that you're able to pull out of them well. And sometimes it gets to the point where you don't pull out of them anymore, sadly.
Yeah. So before we move forward, just to recap, so our thoughts, feelings, mood, and overall functioning are affected, and schizophrenia can cause hallucinations, delusions, and some unusual behaviors. Not everyone, but sometimes we see someone with this diagnosis having cognitive challenges or attentional challenges or problems with memory, concentration, but that doesn't always happen. But what we do see, and we can see this in graphic 1 for a diagnosis, a person has to meet at least 2 of the following criteria out of the 5 that are up there. So number 1, a person must have either delusions or hallucinations or disorganized speech. And we talked about this in one of our other sessions, but just to define hallucinations, when we think of hallucinations, we usually think of visual. I'm seeing something that's not there, that can't be seen by anyone else. But often a person will experience auditory. Sometimes they may be what's called command hallucinations, where there's this voice or voices saying do this or do that, but giving very explicit directions. Other times there may be voices that a person hears saying very negative thoughts. It might be I'm worthless, people are all laughing at me, no one cares about me. It's often very negative self-talk. Then delusions, going back to hallucinations, they could be tactile. Sometimes a person will just feel that there are bugs crawling all over them, right? Any kind of a feeling on their skin or pressure on their skin, on their body, that is not there. Sometimes there's a sense of smell. Like I smell something burning, or I smell something that's not there. So anything through the senses that's distorted to that degree. But then we're also looking at delusions, where we're looking at belief systems, right? So no one knows it, but I am really a great queen, or descendant of some Egyptian king, or feelings of grandiosity, those kinds of things that is it possible? Well, remotely, but typically it's just these beliefs, ideas. Disorganized speech, that a person doesn't really make sense in what they're saying. If you, the thing about this is, if you were hearing the information, just hearing the tone and the pitch, it may sound normal. It may sound like a normal conversation. But then when you really listen, a person is putting words in there that don't exist, or the whole sentence doesn't make sense, but it sounds like it does as far as rhythm, pitch, and a person may present normally as they're saying it. And then it's only afterwards you're thinking, during you're thinking, that doesn't quite make sense. It's very disorganized. So the person would have to meet at least one of those 3 criteria: delusions, hallucinations, or disorganized speech. And then a second criteria, which could be another one of those 3, or there would be a very disorganized behavior or catatonic behavior. And when we say catatonic, catatonia can be present in other areas as well. We can see that sometimes with autistic individuals and with other mental health illnesses. But when we're talking about it here with schizophrenia, there's a tendency to either just kind of get stuck, just not move, right? Or there may be very erratic, unusual types of movement. Right? But sometimes you will see the individual just sit in a certain position and they won't move. And then we see negative symptoms, which means there's as far as the emotional expression, it's kind of drained. There's a lack of it. There's almost like what we might call a flat affect. So there's not much emotional expression. Could also see something that looks almost like a depression, like depressive type of symptoms. So kind of flat. On the other hand, sometimes we can see mania. Person's very manic, right? Physical agitation, can't sit still, moving around, refusal to eat, right? And sometimes individual could just be staring and just not very responsive. So those are the 5 criteria for a diagnosis, and we said an individual has to meet at least 2 of those criteria. When we talk about positive and negative symptoms, it can be a little bit misleading, because it sounds, it can be interpreted as, good symptoms and not so good symptoms. But in this case, when we talk about positive symptoms, that means the symptoms that are present, that we are seeing right now. So it could be that a person has very, very highly exaggerated ideas or perceptions, right? Way, way above what we would normally see. And they have difficulty telling what's real and what's not real. So some of the positive symptoms are, like we said earlier, hallucinations, auditory, visual, olfactory, also taste can be one too, and tactile. Another positive symptom would be delusions. Sometimes, because there are different types of delusions, sometimes a person could experience beliefs that people are against them, or a specific individual is against them, that can clearly, for that individual, be really upsetting. It could cause a lot of distress, because they really feel that that's true, so someone's following them, tracking them, or watching them, and then that creates more anxiety. Another type of delusion is called referential. You'll see sometimes an individual who say, well, I put the TV on and the news person was telling me, was talking to me, so it's taken as a personal event, a personal communication. I turned the radio on and they were talking to me directly. That message was meant for me. Somatic delusions, where a person may fully believe that there's like a serious medical issue that's happening, even though they've been seen and there's no medical issues. It may be that they feel that they're getting damage from the sun's rays, right? Or that people are able to see into their head and see their thoughts. So there's a variety of these types of delusions. The grandiosity we talked about, they're very, very special. And also religious delusions. I am the next, holy leader, or those kinds of things. Other positive symptoms are confused thought, disorganized speech. So a person may feel, you may feel when you're talking to that person that they're not really actually talking so much to you as kind of through you or at you, and not clearly making sense. A person may have a lot of problems, difficulty concentrating. So even if they're watching a short, 10-minute video, they just couldn't attend to it. And movement disorders. So a person may start to repeat the same movement over and over again. So it could be just touching the head, but you keep seeing it. So it could be small motor movement, could be a larger movement. Or then, as we said, catatonia, where a person may actually sit still, not move for literally hours until they gradually come out of it. The way that schizophrenia is depicted is almost always the person's very violent, but typically the person is not. It's very rare to see violence with its population. So, but those are all what we would term positive symptoms, the presence of these symptoms. Then when we look at negative symptoms, we're looking at behaviors that stop happening, things that stop happening, that affect or that affect mental function in this case. So it's the absence of ability to think clearly, plan, in judgment, in our behavior. Behavior is just kind of disorganized, and our perceptions. So what we might see with negative symptoms is that kind of almost like a depression of person's very there's inability to feel positive, happy. Nothing's enjoyable. So everything is kind of
self-care too. There's a lack of self-care often with these individuals. You'll see that deteriorating. And a person might, that their communication may be reduced. They don't really talk, they don't really have much to say. With all of these positive and negative symptoms, often they will reach to substances to try to medicate that. And you'll see an escalation of use of cigarettes, marijuana, maybe even some other drugs. Unfortunately, a lot of that will also increase the symptoms, and they might initially give a little bit of a relief when you initially consume it, but as you continue to consume it, or as it wanes, as it wears off, it usually escalates the symptoms, and then that becomes another layer of trying to do treatment, and makes it very difficult to do treatment with these people and get the right medication and things for them. Because sometimes they even get a dual diagnosis because they use so much that they start to develop a problem with the substance in addition to the mental health problem.
So we're seeing this what's called flattening. The voice sounds monotone. There's not really much expression. It's very flat. The expression can seem very flat. There's not really much of a range of expression at all. Same expression, same flat voice. They may not smile much. They may not, in a conversation, respond at all to it, just be the same. So that's another negative symptom. Withdrawal, so going a little bit further and actually no longer even making any plans to do anything, almost becoming a hermit. You know, I'm totally withdrawn, and it's very hard to even have a conversation with a person. And day-to-day activities, daily self-care, like you said, tends to suffer. So a person may not clean their teeth or have a bath or wash their hair, or just day-to-day activities start to drop off. And they have a hard time sticking with anything through to the end. So they may start even a small task and it remains unfinished. So there's a lot of negative symptoms, and typically, like we said earlier, tendency not to follow through with medications. There are medications that can be very helpful with these symptoms, but it fairly frequently, when someone's doing really well, they'll stop taking it, and then you go back into this.
And some of the antipsychotics, which is what they would use to treat this, to treat schizophrenia, some of them can have very severe side effects, and that also causes them to not want to continue on the medication, sadly, and then you're caught between, you know, the medications can be very effective, but the side effects sometimes are so overwhelming that it makes it not makes them not really able to continue using them.
It's estimated that there's about 1 in 100 people, at least in the United States, that are diagnosed with schizophrenia, and that there's a mix of genetic and environmental causes. So it's not like there's one thing, it's this mix. Another important thing, along with the antipsychotics, is that being engaged in therapy can be very helpful too. You know, a therapist can, besides, you know, helping a person be aware and perhaps question some of these thought patterns, helping support them and helping them stay on track, reminding them of things, you know, so they may be, you know, able to notice when a person's starting to deviate. Are you taking your meds? You know, they may be the first person to know that this person's not been taking meds for a week, you know, and help them get back on track more quickly.
Or help them to recognize the warning, the red flags of escalation, so that they can check themselves into a hospital, you know, preemptively, so that they can get the help they need before something escalates. And also, I think a therapist can help them with anxiety reduction, because a lot of it, again, is fueled by anxiety will take those symptoms. If they have an event that occurs to them in their life, it's going to escalate the symptoms.
With the correct treatment, there are some people with schizophrenia who do recover. It's estimated that about a quarter of people diagnosed with schizophrenia who get treatment get better within 6 months to 2 years. And then there's about 35 to 40% who see really significant improvements in their symptoms after engaging fully in treatment, right? That enough of an improvement so that they can live relatively independently and not have to be inpatient somewhere in residential treatment. So it's a fairly high amount, high percentage, you know. But that's the thing, engaging in that treatment. Okay, so thank you for joining us today. We hope that you found the information that we shared helpful. If you have any questions about what we discussed, please give us a call at 508-623-3931, or you could email us at phoenixinfo.online. Also, if you have any thoughts about something that you would like to see us discuss, same thing, you could give us a call, 623-3931, or contact us via email. And thank you for joining us today.